Incontinence and shaking do not equal a seizure. If you rely on those features alone, you are going to misdiagnose half of your patients. Today, we are breaking down the big three: seizure, syncope, and PNES, using a chronological framework that ensures you never miss a mimic like TIA or migraine. By the end of this, you'll have a clear mental map to navigate any paroxysmal event at the bedside. Here is the first thing you need to reset. The event itself is often the least reliable part of the story. The diagnosis isn't in the shaking. It's in the seconds before and the minutes after. To get this right, you have to look at the timeline in three distinct phases. Phase 1, the pre-ictal window. This is where you distinguish the warning. Ask about the prodrome. In syncope, patients describe a graying out, tunnel vision, nausea, or sweating, often triggered by prolonged standing or a vasovagal trigger like a blood draw. Compare that to a seizure aura. You're looking for a rising epigastric sensation, déjà vu, or olfactory hallucinations. This distinction matters clinically because of the spread. Seizure symptoms spread over seconds. Migraine auras march over minutes. If the symptoms are negative, like sudden numbness or loss of power, think TIA. If they are positive, like tingling or jerking, think seizure. Phase 2, the ictal semiology. Now, let's look at the event itself. Remember this rule: syncope is a flaccid fall, a rag doll. Seizures are usually a stiff, tonic fall. Watch the eyes. In a seizure, the eyes are almost always open, often with a fixed gaze deviation. In PNES, or psychogenic spells, forced eye closure is highly specific. If you try to open the patient's eyes and they resist or show eye flutter, you are likely looking at PNES. Next, look at the movements. Seizure movements are synchronous and rhythmic. PNES often involves asynchronous thrashing, side-to-side head shaking, or pelvic thrusting. If you see convulsive syncope, remember it is brief, usually less than 15 seconds of low-amplitude twitching that happens after the loss of consciousness, not at the onset. Phase 3, the post-ictal state. This is your diagnostic anchor. This is where most people go wrong by rushing the assessment. Syncope has a rapid recovery. The patient reorients in less than a minute. A true seizure has a slow, foggy recovery. Post-ictal delirium or confusion is the hallmark. Look for lateral tongue biting, not the tip, the side. It is one of the most specific markers we have for a generalized tonic-clonic seizure. Think about the ambulance test. If a patient reports waking up in an ambulance but the paramedics say the patient was fighting them or pulling out IVs, that is post-ictal confusion. That's a seizure. If they wake up lucid and asking what happened, that's syncope. If they recall the events inside the ambulance perfectly, suspect PNES. To summarize, first, check the warning. Aura for seizure, prodrome for syncope. Second, check the eyes and movements. Open and rhythmic for seizure, closed and thrashing for PNES. Third, look at the recovery. If it's slow and confused with lateral tongue biting, it's a seizure until proven otherwise.